Good morning, everybody. Welcome to the plenary session, the 2019 Alliance Spring Group meeting. We have a very interesting and packed agenda for you, so I'm going to go ahead and get going. First, I want to give thanks for generous meeting support from Lily, who was the primary sponsor of the Alliance meetings this year. I also want to remind you that Alliance receives a tremendous amount of support from partners in the industry for our work. Fully 50% of the funding that powers research we do for the National Clinical Trials Network is supported by various collaborations with industry. So our research teams are very grateful, and our patients are very grateful for this level of support. I have some appointments to announce to you, lots of interesting and exciting appointments. We have a new chair of the Constitution and Bylaws Committee, Tony Jaslowski, who has been a longstanding member of this committee, and we're very grateful for him for taking over this task with the retirement first of Rocky Morton and then of Bruce Peterson. Next, we have appointments as 3 co-chairs of the immuno-oncology community. David Cozano, a radiation oncologist, expert in immuno biomarkers and lung cancer treatment. Beth Mittendorf, breast cancer surgeon and researcher at Dana-Farber, and Andy Nixon, who has been one of the main leaders of the translational research program within Alliance for quite some time. You can imagine with the field of immuno-oncology and how exciting it is, number one, but also number two, with the tremendous challenges we have in trying to understand which patients are going to benefit and which patients are not. And this really is one of the most crucial questions we have in oncology right now, and we're just delighted to have this new committee helping to address this on the research end for Alliance. Next is an appointment of our chair for the Transplant and Cell-Based Therapies Committee. The field is moving on, and now we are increasingly seeing application of cell-based therapies into the field of oncology. This activity is now housed in our former transplantation committee with its new name. Miguel Pareles from Memorial Sloan Kettering is chairing this committee, which also has very heavily involvement from the leukemia, lymphoma, experimental therapeutics committees. So this is very exciting for us. We have vice chairs also of the new Transplant and Cell-Based Therapies Committee, which include Dr. Tom Shea and Dr. Bill Wood, both from UNC. We have new vice chairs of the Breast Committee, Shelley Wong from Duke and Matthew Popp from Huntsman Cancer Institute at the University of Utah. Congratulations. And a new vice chair of the Health Disparities Committee. Congratulations to Dr. Bruce Rapkin, who is a professor of epidemiology and population health at Albert Einstein. Always at these gatherings of all of the Alliance members who come to the meeting, we have a task of acknowledging and remembering members that are very dear to us who are no longer with us. And we really have 2 very special people who've left over the last 6 months since our last group meeting. Artie Huria, who was the co-chair of the Alliance Cancer and the Older Adult Committees and who did her work at the City of Hope in geriatric oncology. And also Dr. Christy Richards, Associate Professor of Medicine at Weill Cornell Medical College, who was very active in the Lymphoma Committee and the Pharmacogenomics and Population Pharmacology Committee. So with this, I'd like to ask everyone to stand for a moment of silence in honor of our colleagues. Okay, thank you very much. Moving on to new appointments. We have lots of new staff, and you know, I can't tell you how important it is to that we are able to welcome such a talented, new, vital group of new staff members into our Alliance Operations Group on a regular basis. Sometimes these are individuals coming in, you know, maybe their first job after completing college or their training. Sometimes it's the appointment of somebody at a very senior level, but you know, underlying and supporting all of the work that we do as clinicians and researchers is this incredibly dedicated staff that joins Alliance and makes it their real mission. And so I really ask you to, you know, look at these new faces and welcome them when you see them in the hallway and you look at their badge and you see that they're a new member of the staff or a member of the staff, because they are such an incredible force for our work, and we are so lucky to have them. So a few new faces that I ask you all to welcome. At the SDC, Megan Williams, who's the new Director of Information Systems. Han Zhu, who's a senior PhD statistician. Sharmila Giri, a master's level statistician. Patrick D. These are the statistical programmer analysts. I'll just remind you that this is a special position that our Statistics and Data Center has. These are the people who, frankly, really make things happen for all of us. Patrick D., Cecilia Mitchell, and Christy Stolzenberg. Also new data coordinator and quality assurance analysts, 5 listed this time: Kayla Benson, Adam Eggert, Marissa Grant, Tony Mockley, and Aaron Steele. A new analyst for reporting, analytics, and business joined the group, Sandra Cabral, and a new study builder, Tiffany Bainter. I would like to announce at the group chair's office in Boston a new, actually old member, now recently come back to the group, Amanda Bradley, who is the senior grants administrator in the office in Boston. Also, we have a new senior director of the iCare Data Project, Carrie Reardon, senior accountant in the finance group, Mara Fohi, and another staff accountant added to the group, Lena Shavs. We have recruited a new site engagement manager. I hope you'll all get to know Daniel Jones quite well. We've been really searching for the key person to help make life easier and more effective in bringing our sites into Alliance Foundation Trials Research, and we're very delighted that Daniel has joined us for this. We have a new project manager, Joseph Gagnon, and a new quality manager, Majigami Ramos Bordenaro. We also have new CRA, Anna Rappaport, and Christina Patel is our meeting coordinator. I'd really like to have a round of applause for Christina and this wonderful meeting. Christina is the person when we get to this meeting and, oh no, we forgot. She fixes it, and that's why you see things happen at the last minute and happen successfully. Thank you, Christina. Finally, new administrative assistant and meeting coordinator, Caitlin Cam, who will also be helping Christina, and a support specialist, Mary Wiggins. We have a new protocol coordinator in the Chicago office, Diane Feldman, and there we go. Now I'd like to show you a slide that Sherry Bro puts together for us, and it is always very gratifying to show this slide. I know it's small print, but take a minute to look this over, because it doesn't matter what we do until the world gets to hear about it, until it's in publication. And I think, I'm sure you all join me in congratulating the authors who published all of this fantastic work for Alliance, but also notice that more than half of our publications really are in very high visibility journals. And over the last, the year spanning 2018, you see a really spectacular collection of very high visibility publications. So congratulations to all the way from the committee chairs to the study chairs to the protocol coordinators to the staff in the central office that figured out how to find the funding for the things that weren't supplied that really made this happen. I mean, it's very important to see these publications and remember that so many people who don't get recognized on that author list had to be there doing everything they do so well in order to make it happen. So again, a round of applause for everybody who contributed to this. Okay, a few more quick things. ASCO coming up, couple weeks. We have some, I have some announcements to make. We have some ASCO oral presentations this year, and I just want to acknowledge the individuals who've achieved this. For the GI Committee, Emily Bergsland will be presenting A021202, prospective randomized phase 2 trial of pazopanib versus placebo in patients with progressive carcinoid tumors. Congratulations. Next, Michael Morris for the GU Committee, A031201, phase 3 trial of enzalutamide versus enzalutamide, abiraterone, prednisone for metastatic castration-resistant prostate cancer. Congratulations to Michael and the GU Committee. And finally, Jonathan Rosenberg, also for the GU Committee, CALGB legacy study 90203, randomized double-blind placebo-controlled phase 3 trial comparing gemcitabine and cisplatin with bevacizumab or placebo in patients with metastatic urothelial cancer. So, round of applause, congratulations to our ASCO presentations this year. Our important dates. We have the November 7th through 9th will be our fall group meeting at Lowe's Chicago O'Hare Hotel. We look forward to seeing you all there. And one more very important announcement. At the time of our fall meeting, we're going to have kind of renew a previous program that was sunset a couple years ago in Alliance, but we think it's time to bring this back. And this is our institutional principal investigator workshop. Just to put in a plug for anyone who wants to please attend. The target audience is new or junior institutional principal investigators and administrative staff members. It is never easy to fit clinical trials, and especially federally funded clinical trials, into the incredibly complex and busy activities at our institutions. And one of the things that we think we can try to do is to better support the leaders at the institutions to make this possible. So we really want to invite leaders and also their administrative staff members to come to this workshop. Please let us know if you have particular needs for additional travel funding for people to come to this. We really want to make this inclusive. We want to make this a meeting that really can help support the sites. The objectives are to provide an overall introduction to Alliance scientific and operational structures, and then really to review the institutional PI roles and responsibilities, talk about strategies for the academic versus the community sites, and think and share throughout the group best practices for really making our work effective at the various sites. So please send any recommendations or ideas or requests for this meeting so that we can make it as rewarding as possible to Trini over the next couple months. And we look forward to seeing anybody who wants to participate in this first workshop, which will be over several hours during the day. So it'll be a carve-out of the meeting, much as we do our spring new investigators course. And if this is successful, what we anticipate is that every spring we'll have the new investigators workshop, and every fall we'll have the institutional PI workshop, so that this conversation and problem solving can keep going on a regular basis. So I think with that, I would like to invite Steve Alberts to the podium to introduce our Charles Mortel lecturer.
Thank you, Monica. It's my pleasure this year to introduce the Dr. Charles Mortel Lectureship Award. This is the 23rd year of the award. I think many of you in the room will recognize Dr. Charles Mortel. He was truly one of the giants in oncology and helped develop the field to where it is today. Dr. Mortel, starting off as a gastroenterologist, had a strong interest in cancer, and through that interest led to the development at Mayo of the Department of Oncology, and within it the Medical Oncology Division, but importantly also the Cancer Center. But beyond that, Dr. Mortel was particularly interested in developing new therapies for patients and demonstrating that those therapies were not only a benefit, but could be given in a community setting. In that regard, Dr. Mortel developed the North Central Cancer Treatment Group in 1977. Well, that activity was initially focused in the upper Midwest, including Montana. By the height of its activities, it had spread to a total of 36 states and 406 treatment sites before becoming part of the Alliance. Importantly, Dr. Mortel really focused on activities that were focused on the patient, again, bringing forward new innovative treatments, finding ways to take discoveries out of the lab and into the community setting, doing this through clinical trials in a way that avoided bias from sometimes interests of particularly industry in developing new drugs. With that in mind, we've recognized Dr. Mortel now over the last 23 years, bringing the award to people who've carried forward that focus on developing clinical trials that help promote best care for our patients, and really something that can be applied in the community setting. It's my pleasure this year to recognize Dr. Joseph Sperano as the award recipient. Many of you know Dr. Sperano, but Dr. Sperano had initially performed his training in New York, his MD coming from the New York Medical College, internal medicine at St. Vincent's, and then ultimately his oncology training at Albert Einstein in Montefiore. Dr. Sperano is now a member of both Montefiore and Albert Einstein, serving as attending physician and director of the breast medical oncology program at Montefiore and associate chairman for clinical research at that institution. In addition, he also is associate director for clinical research at Albert Einstein, a professor of medicine, as well as a professor of obstetrics, gynecology, and women's health at Albert Einstein. Dr. Sperano has accomplished many things through his career. He is currently a professional leader in many national or international activities, including being on the board of governors of ECOG Akron, the co-director for ECOG Akron Young Investigators Program. He's the chair-elect for the AIDS Malignancy Consortium and the chair of the ASCO Nominating Committee. Dr. Sperano has served as the PI of many grants. Importantly in this regard, for active ongoing grants, he's the holder of the UG1 award from the NCORE for minority underserved sites. He's also the holder of a V Foundation grant that's focused on what's entitled Closing the Door on Metastases, a new biomarker and treatment paradigm. And finally, he's also co-PI of multiple other large grants. Dr. Sperano has accomplished many things through his career, developing numerous clinical trials, and not only in breast cancer, but notably in GI cancers, hematologic malignancies, and AIDS-related cancers. He's a member and leader of numerous national and international committees, as well as publishing multiple papers in regard to his works, as well as presentations. In regard to the lectureship today, one of the nominating letters came in, really captured the key attributes of not only Dr. Sperano, but his alignment with the Mortel lecture. In that letter, it was noted that the Taylor RX trial that was presented last year at ASCO was a landmark trial which will change the management of breast cancer in tens of thousands of women, notably focusing on treatment de-intensification for select women with breast cancer, carrying forward what Dr. Mortel and others had done in regard to colon cancers and other areas of GI malignancies. So in that regard, please help me congratulate Dr. Sperano and this year's award recipient of the lectureship.
Well, thank you very much. It's certainly a great honor and a pleasure to accept this award. I had no idea that I was nominated, so it was really a wonderful surprise and privilege. And the title of my talk is Pursuing Progress and Precision in Cancer Care, and I'm going to give you two examples of trials that I've been involved with, had the privilege of being involved with, that I think contributed to some progress, either directly through the primary trial results, or perhaps more importantly, through some of the secondary analysis that was done of that one trial. And secondly, precision, a large trial that I think helped better define how to best treat patients. But I think probably the most important aspect of this is the last part, through collaboration. None of this would have been possible without collaboration. It brings us together, it defines us, it empowers us, and it allows us to move the field forward. So it turns out that one of Dr. Mortel's many publications, this was a very important one, and it reflected his interest in GI cancer and the power of collaboration that he established through the development of the cooperative groups. And I read this, I remember reading this actually as an assistant professor back in 1990 with Dr. Mortel as the lead author. And my primary interest at that time was because at that time I was actually a medical oncologist interested in immunotherapy, when immunotherapy was high-dose interleukin-2 and lac cells. And the topic of this paper included levamisole, which was thought to have immunomodulatory properties. But looking back on this paper, and that's what really drew me to it, but looking back on this paper 30 years later, it really illustrates the power of collaboration and what we can do together that we could never accomplish as individuals. First, it was a large study that involved over 1,200 patients. Secondly, there was a large treatment effect of the intervention, resulting in a reduction in recurrence of colorectal cancer and reduction of colorectal cancer death. And lastly, in the bottom right, if you can see it, Dr. Mortel, in the conclusions, emphasized the fact that this was done largely in the community, and this was directly applicable to the community, and not something that could just be done in an ivory tower. And that really sort of embodies the principles of the cooperative group, the NCI-sponsored cooperative group system, and what brings us together. So moving on to progress, I thought it would be fun to give an abbreviated history of cancer clinical trials to tell us how we got to where we are right now. So in medicine, the first clinical trial that I was aware of was performed by Sir James Lynn, sailor, captain, who did a randomized trial of citrus in 12 sailors and proved that, that the citrus can prevent scurvy. This contributed to the English sailors being called limeys. And then in the 1800s, the basic principles of epidemiology were first described in a case control study of venesection for pneumonia in 77 patients, and this disproved the teachings of Galen that had existed for nearly a millennium. In the early 1900s, Congress established the Public Health Service, later the NCI, and in 1948 the NIH. And it was around this time that descriptions of methodologies for clinical trials began to appear in the literature in the New England Journal of Medicine. And the first randomized clinical trial that I'm aware of was a randomized trial of streptomycin for pulmonary tuberculosis. In that year, in cancer, same year, 1948, Sidney Farber first described temporary remissions in 6 children with leukemia treated with aminopterin. And about 5 years later, James Holland then reported the first clinical trial of acute leukemia. The U.S. Senate in the 1950s then directed the NCI to establish a cooperative system, leading to the cooperative group system. And Tom Fry soon thereafter described the first randomized group trial in leukemia that was done by the acute leukemia group A. And a couple of years later was the first trial in solid tumors reported by the ECOG group. And then in 1971, President Nixon signed the National Cancer Act and declared the war on cancer, which established the NCI designated cancer center system. And fast forward to 2010, when the IOM report resulted in the reorganization of the cooperative groups in 2014. So this is actually the first randomized trial in a solid tumor that appeared. And the primary results are pretty forgettable because it was a comparison between nitrogen mustard and thiotepa, I believe. But what's really interesting about this publication is, and what's most important, it makes it a seminal publication, is that in the appendix is the protocol. And it really remarkably resembles the modern protocol that we use today in clinical practice, and described the selection of patients, the pre-treatment variables, the studies during treatment, what they call the mechanics of the study, dosing of the drugs, records to be kept, and also first established the dreaded flow sheet, at least dreaded to many fellows, medical oncology fellows who trained in my era, because that was our job, was to keep the flow sheets. There were also the tables, in terms of how the tables were organized, sort of recapitulated how the structure of publications that we now routinely see. And we also saw a Kaplan-Meier curve comparing the outcomes for these 2 treatment interventions. So to move things a little further, not too far thereafter, Susan Horowitz at Albert Einstein, my institution, described the novel mechanism of action of Taxol. It was called Taxol back then, originally then changed to paclitaxel. And then fast forward 30 years later, I had the opportunity to lead a trial through ECOG, which identified what many believe to be the optimal dose and schedule of Taxol in treatment of early breast cancer that led to improved survival. And as I mentioned before, oftentimes the primary analysis may not be the most important conclusions. There have been a number of secondary analyses from this trial, including one where we evaluated the effects of obesity on outcomes and demonstrated, and were able to disentangle many of the confounding effects and show that despite similar treatment, patients had worse outcomes if they were obese, and specifically saw an interaction between ER-positive disease and worse outcomes. This turned out to be replicated in a meta-analysis that was done by the Oxford group, and it helped contribute to the genesis for the ongoing Be-Well trial. We also did another secondary analysis showing inferior outcomes specifically for Black women with estrogen receptor positive disease, used the biosamples from this study to identify a SNP associated with taxane-induced neuropathy that we see more commonly in Black women. And to my knowledge, have now launched the first prospective trial specifically in Black women with breast cancer to prospectively validate this SNP and its association with paclitaxel-associated neuropathy, with the notion that if we do validate this, we can use this to tailor the type of taxane therapy we offer to African American women in the future. Now moving on to precision, This was the challenging part because breast cancer mortality rates had declined by about 40% over the last 30 to 40 years. And this was because of, in part, due to screening, but also improved adjuvant systemic therapies, including endocrine therapy and chemotherapy. So if we were going to now use assays, tests to help de-escalate therapy, we really had to make sure that we did it in a rational and a very careful way because we can compromise some of the gains that we had made in the last 30 years. And the key to driving this was the integration of biomarkers into our clinical practice. So I'll speak about biomarkers in general, gene expression profiles in particular, and how we define the clinical utility of these. Well, the role of biomarkers in breast cancer is not new or unique. We've been using them for many years. The first generation included protein markers for ER/PR. The second generation included gene amplification for HER2. But it was around 2004 or so that we now had gene expression assays that can provide more robust prognostic information. And it was around that time we began designing trials to try and leverage the power of those assays. So in terms of the challenges that we had in implementing this, the three key attributes of a biomarker and applying them to clinical trials and clinical practice are, first and foremost, analytic validity, the assay reliability and its reproducibility from lab to lab or within the same lab. Second, clinical validity, that is an association with a clinical outcome. And many biomarkers we can check off both of these boxes, analytic validity and clinical validity, but it's clinical utility that's the most challenging. And that's what we tried to embark upon about 15 years ago. And that is to demonstrate, does the use of this biomarker result in a change in treatment, and do patients benefit from that change? Now, the typical way for establishing or a new therapy or testing a biomarker can include the standard prospective clinical trial, which provides level 1 evidence. But about a decade ago, Dan Hayes and Richard Simon and Soon Paik published a seminal article that conceptualized a new model for testing biomarkers, and that is using archival specimens from completed trials where we already had long-term data, and then proposed that these can provide level 1 evidence to support the use of a biomarker if we had consistent results. And so now I'll be walking through some of these trials that will describe this level 1 evidence. So those are some of the fundamental principles. What about the biomarkers? Well, one of the former Mortel recipients, Chuck Peru, described now 15 years ago the first reports of gene expression profiling breast cancer showing that breast cancer is a heterogeneous disease with distinct subtypes whose prognosis varies by stage. And those experiments that were done by unsupervised analysis then led to gene discovery experiments that were done by supervised analysis, looking at gene expression patterns in relapsers versus non-relapsers. And that led to the development and validation of the 21-gene Oncotype DX recurrence score and the 70-gene MammaPrint assay. And I'm going to focus on these two assays because they've been the subject of prospective clinical trials. But I'd like to point out a couple of things about both of these assays and all of these assays in general, which generally have clinical utility and validity only in ER-positive, HER2-negative disease. Firstly, the panel on the left shows that for the 3 different subtypes, triple-negative on the far left, ER and HER2-positive in the middle, and ER-positive, HER2-negative on the far right of each one of these panels, that you'll see that this represents the proliferation scores from 6 independent data sets. And the red indicates high scores, the blue indicates low scores, and what you'll see is, it's no surprise that triple-negative, HER2-positive disease has higher proliferation scores, but there's heterogeneity within the ER-positive, HER2-negative subset. So some have high scores, some have low scores. The second important point is that this ER is also important in driving these scores and the validity of these assays. One of these assays, of course, is a 21-gene expression assay, which includes a proliferation cassette, HER2 cassette, estrogen cassette, and invasion cassette. Each one of these genes RNA expression is evaluated with a range of 1 to 15, with each integer representing a 1 log increase. The average of these cassettes is averaged and then adjusted based on the formula on the upper right-hand panel. And what this shows you is that what's driving the score mainly is the proliferation will drive the score up because it has a high proliferation. It has a high coefficient, a positive coefficient in the highest level. And what drives the score down is ER. And it's really proliferation and ER that drives this gene expression assay, like many other gene expression assays. A second important point about these assays, and this is a busy slide, the point of this slide is that when you compare here 4 different assays, the point is they don't always classify patients in the same way. They don't classify patients equally as high risk or low risk. In fact, it's sort of like the flip of a coin. There's about a 50% chance you'll get a different answer with a different assay. But if you're going to use an assay and use it for the idea of sparing the use of cytotoxic therapy, then one of the characteristics of the assay is important is how many patients does it classify as being in the highest risk that could potentially benefit from chemotherapy. And if one looks at the 21 gene recurrence score and uses 26 to 100 to classify this high risk, you'll see that this is about 18% versus about 2-fold higher for 2 other assays. So this is an important point. So how do we define the clinical utilities of these assays? We'll start with the prospective validation studies. The first was the study establishing prognosis for the 21 gene assay in 668 patients with ER-positive node-negative disease treated with tamoxifen. And you could see that about half of the patients had a low score that was predetermined of less than 18. 25% had an intermediate score and 25% had a high score. And the 10-year risk of distant recurrence was 7, 14, and 31%. The bottom left showed you that if you plug this into a multivariate model, it retained its independent significance. And the panel on the right shows you that you can also identify with fairly good precision the likelihood of a distant recurrence for patients who had an individual recurrence score within these different subgroups. Another important point, which has never been published, it's only been presented, is when you compare the outcomes for patients treated with tamoxifen in green versus placebo in the B14 trial, the good prognosis for patients with low and particularly intermediate recurrence score depends upon their taking endocrine therapy. And that's a very important point. I think the game changer was when the results of the B20 trial came out. This was a trial that looked at patients who had ER-positive node-negative breast cancer treated with tamoxifen with or without CMF. They had samples in about 650 patients. The panel on the left shows you there was a small 4% improvement in disease-free survival. But the panel on the right shows you that when you looked at the subset of 25% of patients who had a recurrence score that was high, defined as at least 31, there was a very large absolute 25% benefit rather than a 4% benefit. And the inset panel on the left shows you that that absolute benefit is substantial. And really, you're treating all of these patients here, but it's only the subset of patients who are deriving the benefit from therapy. And this was subsequently validated in another data set in older women with node-positive disease, looking at CMF chemotherapy, the CAF chemotherapy. The prior study was CMF-based chemotherapy. So this was important, but we need more data. So what about population-based trials? Is this information, are these assays generalizable to the population? And this is data from the SEER database, where it was linked with the Genomic Health database, nearly 40,000 patients with node-negative, nearly 5,000 patients with node-positive disease. And you could see for those patients who had a low, intermediate, or high recurrence score, 2 things. Number one, higher recurrence score drove the greater use of chemotherapy. And second, higher recurrence score was associated with greater 5-year breast cancer-specific mortality. And thirdly, for those who had a low recurrence score, they had excellent outcomes, low breast cancer mortality when treated with endocrine therapy alone. So this brings us to the prospective clinical trials, and TAILOR-X in particular. So this trial enrolled 10,273 patients between April of 2006 and October of 2010. The target population was patients who had ER-positive, HER2-negative, node-negative breast cancer who met NCCN guidelines for recommending or considering chemotherapy. And the patients who had a mid-range score of 11 to 25 were randomized to chemoendocrine therapy, the control arm, versus endocrine therapy alone, the experimental arm. For the third of patients who had a score that was either low or high, we treated them based on the evidence that we had at the time, which included chemoendocrine therapy for high scores and endocrine therapy alone for low scores. So as I said, the key eligibility criteria included no negative ER-positive disease. It was a non-inferiority design. And the bottom line here is based on the B20 data, we expected about a 5% distant recurrence rate at 10 years in this population, irrespective of chemotherapy. One of the key issues regarding this study is that we changed the recurrence score ranges, and we did that for several reasons. First of all, the TAILORx population excluded HER2-positive disease, and that's important because a 21-gene assay includes a HER2 module associated with higher recurrence, and most HER2-positive tumors have a high recurrence score, resulting in a different recurrence score distribution if you only test patients who are HER2 negative. In addition, in around 2005, we then had targeted adjuvant therapy for patients with anti-HER2 therapy for patients who had HER2-positive disease. Secondly, the recurrence score is used selectively in practice when there's therapeutic equipoise. This is typically in patients who have tumors between 1 and 2 centimeters in intermediate grade. So the clinician who has a 6 millimeter low-grade tumor is not going to test that patient, nor a 3 centimeter high-grade tumor in a 35-year-old. So there's bias in the application of the test. And then, which you would completely lose if you had a binary test of high versus low, but you maintain a window on that change by having this continuous score. And then the recurrence score was adjusted for the mid-range based on B20 in order to preserve prediction in the high-risk group and minimize the potential for undertreatment. So here are the curves for patients treated on the B20 trial, TAM plus chemotherapy in green, tamoxifen in yellow. The difference is the benefit of chemotherapy. And here, this is the initial recurrence score is described. 18 to 30 was mid-range, and we moved that to the left to 11 to 25. And we expected a 5% distant recurrence rate at 10 years based on data from B20. And this is that data. When we reanalyzed the data from B20, looking at 11 to 25, we saw about a 5% 10-year distant recurrence rate and no benefit from chemotherapy. Well, the first results came out in 2015 from the low-risk registry, and we found that for those patients who had a recurrence score of 0 to 10, that at 5 years they had a less than 1% distant recurrence rate with endocrine therapy alone. A very good rate, and we're very confident that this is not a group of patients who would benefit from adjuvant chemotherapy. The next results came in 2018 when we learned the results of the randomized group. And the primary, if I can get to it, the primary endpoint is shown on the left of invasive disease-free survival. This was a non-inferiority study. The hazard ratio was 1.08. We did not cross the non-inferiority margin of 1.32. And you could see that those curves are superimposable. We also saw no difference in the secondary endpoint of distant relapse-free interval. A couple of other points regarding the results at 5 and 9 years. Firstly, there were better 5-year disease-free survival rates in TAILORx than projected. It was projected to be 90% for the chemoendocrine arm. It turned out to be 93%. And secondly, the 9-year distant recurrence rates in TAILORx were similar to the 10-year distant recurrence rates observed in the B20 trial of 5%. So this is a very important finding. We were walking back from chemotherapy, which we had already been doing actually in clinical practice for years, but now we have a much higher level of evidence to support those decisions that we're making every day in our clinical practice, and also had much greater precision. But if we were going to walk back, we really needed to make sure that there was no patients that we were leaving behind, that there was no subgroup of patients who could potentially benefit from chemotherapy. And so we carefully took a look at this, and we found no difference by clinical risk as used in the MINDAC trial, tumor size, or grade. But we did find interactions between age and chemotherapy benefit, and most importantly, age, mid-range recurrence score, and chemotherapy benefit. So that if you were 50 or under, which accounted for about a third of patients in the trial, and you had a recurrence score of 21 to 25, this is in the randomized group, there was about a 3% absolute benefit from chemotherapy at 5 years and about a 7% benefit at 9 years. For 16 to 20, smaller differences, about 1% and about 2% at 5 and 9 years respectively. So this raised the question, what's the appropriate therapy for patients who are under 50? And I'll get to that in a moment. But one of the other questions was, is recurrence score greater than 25 an appropriate cut point for chemotherapy prediction? Remember, we defined it as 31. It was defined by the NCBP as 31. And I'm going to show you several pieces of evidence to suggest that it is an appropriate cut point. First of all, if we looked at the results of TAILOR-X in patients in the prospective registry in Arm D in gray, they had a significantly worse outcome. And that's shown again on the right, where the distant recurrence rates for patients with 0 to 10, recurrence score of 0 to 10, 11 to 25, and 26 to 100 were 3% without chemotherapy, just endocrine therapy alone, 5% irrespective of the use of chemotherapy, and 13% despite the use of chemo plus endocrine therapy, indicating there was room for improvement in this high-risk group. Secondly, when our colleagues at NSABP went back and excluded the 12% of patients who were HER2 positive and repeated their analysis, they found a similar, and used 26 or higher as a cut point, they found a similar absolute benefit from the use of CMF or MF chemotherapy, and there was a statistically significant p-value in an interaction test, again supporting a second piece of evidence. The third piece of evidence comes from population-based data, and this shows you the benefits of chemotherapy from population-based data. Remember, these patients are not randomized to chemo or not, the physicians choose, but nevertheless it can be instructive. And the horizontal line of 1 indicates neutral effect, and you could see that the red line, woman over 50, the line intersects with, at a recurrence score of about 25, indicating that patients with a recurrence score of greater than 25 begin to develop some benefit from chemotherapy. But if you look at the younger patients, 50 or younger, that curve is shifted to the left, and it's in the range of 16 or so. This still doesn't address what the mechanism of this is. Is this a cytotoxic effect of the chemotherapy in eradicating micrometastatic disease, or is it potentially an anti-estrogenic effect? Additional data from this analysis showed that for patients who had the high recurrence score on the right, 26 or higher, there was a benefit from chemotherapy. And analysis in patients with node-positive disease also suggested that those who had a low recurrence score and N0 did very well, which is a good harbinger for the result of the studies that have been completed, the RxPonder trial. What other evidence, prospective data is there? There's data from the Plan B trial. This included patients who had hormone receptor positive disease, up to 3 positive nodes with a recurrence score of up to 11, treated with endocrine therapy alone, and they had a 94% invasive disease-free survival, identical to what we saw actually in TAILOR-X, including an exclusively node-negative population. And finally, we have the MINDAC trial. This is a very different trial where patients underwent a clinical risk assessment, genomic risk assessment, and the focus of the trial was really on the patients who were clinical high, genomic low, who were randomized to no chemotherapy. And so only about 644 patients in this trial of the 6,600 enrolled actually formed the basis for the primary trial endpoint. And they met their primary endpoint of showing that this group of patients had a disease-free survival, a distant metastasis-free survival that that was above 92%. And this has led to the ASCO guidelines suggesting that this would be an acceptable assay to use in a clinical high-risk population is being considered for chemotherapy. We also have the results of the RxPonder trial, which is ongoing, in which patients with 1 to 3 positive nodes undergo testing, and if they have a recurrence score of less than or equal to 25, are randomized to endocrine therapy alone or chemoendocrine therapy, and there is stratification by recurrence score and menopausal status. And there's the Optima trial ongoing in the UK. This is actually the design that I wanted to use in TAILOR-X, but we felt that we couldn't because we had too much information about the assay already, where patients are being directed to a control population where everyone gets chemotherapy versus a test-directed population where only those who are low risk by the genomic signature are spared chemotherapy. What's ongoing in the future? Well, we've already reported, we've actually recapitulated what we saw in TAILOR-X that we'd seen in E1199 and E15103 trials, that black race is associated with worse outcomes in ER-positive disease. We have integrated clinical and genomic risk, which will be an oral presentation at ASCO and with a simultaneous publication. We are in the process of recalibrating the RSPC, which is a tool that integrates the recurrence score with clinical and pathologic data that will allow clinicians to provide more refined estimates for prognosis and possibly prediction of chemotherapy benefit. We plan to, there's been a lot of interest in hearing about further outcomes in the high-risk registry by chemotherapy. We're doing that analysis. This trial has been picked for the clinical trial sequencing project, so we're hoping to have tumor specimens sequenced in up to 600 patients. There's also interest in evaluating local recurrence by recurrence score, and lobular carcinoma, and those are projects that are ongoing or about to be initiated. So to conclude with regard to the precision aspect of the talk, as it relates to molecularly guided management of breast cancer, although breast cancer is a heterogeneous disease, even within the ER-positive, HER2-negative subtype, we can use gene expression assays to help guide therapy. The gene expression assays provide prognostic information with high levels of evidence in ER-positive, HER2-negative breast cancer and in that's node-negative and low-volume node-positive. And it also provides predictive information, including for chemotherapy benefit, level 1B information in node-negative and node-positive patients, and lack of chemotherapy benefit, level 1A from TAILORx in node-negative disease with a recurrence score of 0 to 25. And based on that is now the preferred assay in the NCCN guidelines. And lastly, these assays are not interchangeable. There's a lack of concordance in risk classification. So if you're going to use one of these assays, you should use one that you feel most comfortable with, supported by the highest level of evidence, and not use one assay as a tiebreaker to another assay when you have an equivocal result. So I'd like to acknowledge the many people who contributed to this, including many clinicians, research coordinators, nurses, other healthcare professionals who participated in this trial, to our partners in the advocate community, to the NCI for sponsoring the trial, Genomic Health for partnering with us, and the late Bob Comas, who had the vision to take a gamble on supporting a trial like this. And of course, most importantly, to the 10,273 women who volunteered for participation in the trials. They are what inspire us, and they bring us together to collaborate. Thank you for your attention.
Okay, you know, every plenary session, we try to select one of the major alliance programs or committees to really provide you an update on what's going on in that particular group. This time, I am very pleased to invite to the podium Dr. Amina Jatoy, who is the Associate Director of the Alliance Cancer Control Program, who's going to speak to us about her work and the committee's work on cancer cachexia, a worthy therapeutic target or simply an epiphenomenon. So, Amina, welcome. Thank you.
Well, thank you very much, Monica. I really appreciate the opportunity to come and talk about this topic of cancer cachexia and to address the question as to whether it is truly a worthy therapeutic target or simply an epiphenomenon. And in talking about this area of research, I'd first like to address the question, what is cancer cachexia? Then go on and talk about how the syndrome is currently treated, then talk about new paradigms for clinical investigation, and then readdress this issue of whether cancer cachexia is in fact a worthy therapeutic target, with the goal of, by that point, having convinced you that it is a worthy therapeutic target. So what is cancer cachexia? Years ago, I felt very privileged to have been part of a very large international group of investigators who were interested in cancer cachexia and who were going on to define cancer cachexia based on a multidisciplinary group of investigators who converged internationally. And we came up with the following definition of it. It is a multifactorial syndrome defined by ongoing loss of skeletal muscle mass, not fully reversed by conventional nutritional support, leading to progressive functional impairment. The late Dr. Fearon and others led this effort, and I just want to acknowledge that he had done a great deal in this area of cancer cachexia over the course of his career. But there's a lot of data that this definition is based upon. For example, the Eastern Cooperative Oncology Group looked at 3,047 patients, all of whom at the time of diagnosis had advanced disease. And they found that whether the cancer type was small cell lung cancer, non-small cell lung cancer, breast cancer, colon cancer, or prostate cancer, those patients who had maintained their weight lived longer than those patients who lost weight. And you can see on the far right that those differences in survival were consistently statistically significant. In addition, they looked at performance score and they adjusted for performance score. And although weight loss and performance score were closely tied, even after adjustment for performance score, weight loss remained a powerful predictor of poor survival. And how much weight loss are we talking about? Not very much. The study by DeWeiss and others, which I'd shown you on the previous slide, looked at a range of 0 to 5%. But even patients who are in that, I should say 1 to 5% range, had a prognostic effect as seen with that degree of weight loss. So not very much weight loss at all was at work here in creating, or at least contributing to these poor outcomes. Now, why is this the case? Why is it that weight loss is such a powerful predictor of poor outcomes in patients with cancer? Well, many years ago, Cohn and others did a case control study where they looked at individuals who were relatively healthy and they made comparisons to patients who had cancer and were losing weight. And patients were matched on the basis of gender as well as height and weight. And what they found after doing extensive body composition assessment is the loss of body weight in patients with solid tumors consists of loss of muscle and fat. However, and I think very importantly, it is the muscle mass which is predominantly lost. Cancer patients appear to retain notable amounts of body fat. That lean tissue is what is wasted and what accounts for this poor survival and what also accounts for this decline in functionality that we see in our patients every day in the setting of weight loss. In other words, in the cancer-free state, there's a certain compartment of lean tissue, fat, as seen here. But in a cancer-laden state, in the patient with cancer, there is a wasting of lean tissue that accounts for the morbidity that I've described to you so far. And there have been studies more recently. Lisa Martin and others in 2013 published a paper in the JCO, which showed quite clearly that regardless, even in patients who were overweight, even in patients who were obese, if one looked at CT scans and saw an attrition of lean tissue on that CT scan, that patient was destined not to live as long as a patient who maintained lean tissue. What is that critical threshold where wasting of lean tissue occurs to the extent where life is no longer able to be maintained or sustained? Many investigators say that it's 45%. And that is derived from the fact that in other sorts of compartments, such as muscle, if one infarcts 45% of the heart, one is no longer in a state of being able to maintain life. So this is the critical point after which, again, patients drop off and pass away. But it's important to realize that up until that point, we see consistent degradation of function. We see that patients who are starting to reach that point or move towards that point are losing their ability to do the activities that we all do on a regular basis and that we take for granted. I was very privileged to have been asked by Stu Lichtman to write for the ASCO Post and to be able to write about falls in older patients with cancer. And interestingly, that invitation from Stu led me to think a little bit further about falls and to realize that some of the work that I had been doing with respect to cancer cachexia is directly applicable to older patients. Falls occur in 30 to 50% of cancer patients aged 65 and older, and these can sometimes be highly injurious falls. In fact, those patients, I believe, who are losing muscle mass the worst are the ones who are more likely to fall and the ones who are most likely to sustain a major injury related to a fall. And so I think that this whole issue of wasting ties very nicely to some of the issues that older patients with cancer are also facing. Now, just to cite some alliance data, and you can see I tried to denote the alliance studies or data with the little square up in the far right corner. Jennifer Leigh Rademacher did something very interestingly that was done. She looked at a landmark analysis. Up until this time, all the studies that have looked at the prognostic association associated with weight loss have specifically looked at the time point of diagnosis. And Jennifer asked the question, is this sustained? And she found that, in fact, it was. She used the 2% threshold here. She looked at other thresholds as well, but she found that even after the time of diagnosis, if a patient starts a trial, doesn't lose weight at the time of entry, but then later loses weight, that later weight loss also contributes to or is associated with a poor survival. Why is this landmark analysis important? First, it is the first validation of prospective data. This is a little erroneous there. First, validation of prospective data to show weight loss post-diagnosis predicts poor survival. And secondly, it provides justification for recruiting patients late in their disease course to cachexia trials. We aren't necessarily recruiting patients to cachexia trials at the time of their cancer diagnosis. We tend to do it later, and Jennifer's work provides the justification for our continuing to do so. And I should mention to you, this is basically the data, or I shouldn't say the data, but this is the paper that I alluded to from Fearon and others. I was part of this group that provided the definitions and classifications for cancer cachexia. Some of the numbers that I have alluded to, the 5% within 6 months, the 2%, we see the data as demonstrated by cooperative group data that show us that these sorts of numbers have true validity, and they are, in fact, part of this definition, which has been cited often and was published in The Lancet. Now, what about appetite? Appetite is also very much part of this syndrome. Patients are losing weight for multiple reasons, one of which is the fact that food doesn't appeal to them. And I would say to you what you probably already know. If you look at any list of symptoms in patients with advanced cancer, you will see on that list poor appetite. It's usually within the top 5. And also importantly, you'll see, as seen in this slide, that the majority of patients with advanced cancer tell us that they're struggling with eating. So this is not only a bothersome symptom, but it's also a highly prevalent symptom for patients with advanced cancer. And the same sort of prognostic association is seen once again. These are data from the EORTC by Quinton and others, which asked patients at the time of cancer diagnosis about their appetite. And you'll see here a splaying of curves, with the top curve representing those patients who had a reasonably good appetite at the time of trial entry, and the bottom curves representing those with decrements in terms of their overall appetite. So appetite, too, is a powerful predictor of outcomes and survival in patients with advanced cancer. This is not starvation. And I want to make this fairly clear. In the setting of starvation, we see primarily a loss of fat, but in cancer cachexia, we see not only a loss of fat, but a loss of lean tissue. In starvation, patients are hungry, or individuals are hungry. Some of you might be hungry right now. But in the setting of cancer cachexia, there is no hunger. There's actually a robbing of that hunger. There's a loss of appetite. In starvation, there tends to be a drop in resting energy expenditure. We try to conserve our energy reserves, whereas in cancer cachexia, the data have been somewhat controversial, but for the most part, resting energy expenditure is increased. And in starvation, there have been no specific mediators that have been implicated, whereas in cancer cachexia, there have been several, and I'll show you slides later, including tumor necrosis factor alpha. So in effect, we see the patient with advanced cancer with refractory disease, a situation that is all too common in our clinics as medical oncologists. These patients experience loss of appetite, debility from muscle wasting. They manifest and tell us about a worsening of their quality of life, and they also manifest a diminished survival. Now, just one other quick point, and I don't want to belabor this, but bevacizumab, in a study that we had done a few years ago and was undertaken by Tim Potaruca, who was a medical student at the Mayo Clinic, bevacizumab seems to also have negative effects on muscle. And this is a study where we looked at CT scan images among 57 patients before and after bevacizumab therapy over just a few months, and we found that there was, in fact, a wasting of lean tissue seen on these serial scans. Importantly, we adjusted for tumor response, so this was not in any way associated with degree of response or lack of response. It seemed to be very heavily tied with the bevacizumab treatment alone. And these sorts of findings were confirmed in a subsequent study of 60-some patients that was published in the Journal of Clinical Oncology by other investigators a couple years ago. I don't want to belabor this point, but I do want to say that I've always viewed this as very much a cancer-driven process. Cancer cachexia is what we're dealing with. But as we're getting more targeted therapies that potentially could also have targets in the muscle, there is a possibility that some of the newer agents we're giving to patients might also lead to muscle wasting, and something that I think we should be alerted for and aware of as we go on and treat patients. So how is this syndrome currently treated? Let me start by providing a quote from Jane Hopkinson, a very skilled qualitative investigator in Great Britain. In one of her interviews, she elicited this from a patient with cancer. "Now I just hate eating. At the end of a meal, I think to myself, I'm glad that's over. It's a sort of punishment." Despite that, what do we tell patients? Eat that, drink that, take this supplement. And how effective is that advice that we give to patients? Not very. This is a meta-analysis from Baldwin and others that was published a few years ago that looked at enteral feeding, all these randomized studies that looked at enteral feeding in patients with advanced cancer. And basically, these investigators showed that there is really no survival advantage. There is no diminishment in mortality when we urge patients to take supplements or when we prescribe such supplements to patients. So in effect, eating is not really the best way that we should be approaching this syndrome or advising patients to eat. In contrast, one of our former fellows who's now on staff at the Mayo Clinic, Thor Halfdanderson, did a very nice study where he looked at quality of life based on dietary counseling, not necessarily pushing patients to eat, but in fact doing the opposite, having patients meet with a dietitian, hearing about the syndrome, hearing about implications of the syndrome, and getting gentle advice on how to help deal with the struggle for eating. And Thor and others found, and I was involved with this study and had the great pleasure of mentoring Thor through it, Thor and others found that basically this sort of dietary advice leads to better outcomes, at least better quality of life. So at least this is one approach, dietary counseling, that seems to be worthwhile when we deal with patients who are dealing with these circumstances. What else does not work? And I think it's important to talk a little bit about what doesn't work for a couple reasons. First, it's a long road. It's been a very long road that has led us to some things that do work. And secondly, as we've continued to do these trials, the majority of which I'm about to show you are from the Alliance, we've gotten better at doing them. We've realized that this is very much a multifactorial syndrome, that patients are not just experiencing loss of appetite, but loss of weight, and we've become a bit more sophisticated as to how we've done the trials. So talking through what does not work, I think, is also of great importance. And through the years, we've done something around the range of 1,500 patients going on to such trials, and again, we've learned from all of them as we've gone through these processes. So back to that quote from Jane Hopkinson, "Now I just hate eating." We did a study a few years ago that was published in 2016 that looked at wine. And the genesis for this is that if you looked on the internet back then, just about everywhere, there was this advice for patients who were struggling with eating to drink wine. The thinking was it had some aperitif effects, There were data, and there are data, that showed that it works in healthy people, that if a healthy person takes some wine and they do eat more, and that's been shown fairly consistently. But in contrast, in patients with cancer, 120 patients, we found that it absolutely did not work. Wine had no effect in terms of appetite stimulation. A finding that makes the point that what works in other clinical settings might not work in cancer patients, and in fact generally doesn't work in cancer patients. This is a unique population with unique needs. We did another study. We actually did two. We did other studies, two other studies with TNF-alpha inhibitors. The first one that I skipped over was etanercept. This one, infliximab, both inhibit TNF-alpha. And again, the preclinical data seem to suggest that this whole syndrome was very markedly driven by inflammatory cytokines, specifically TNF-alpha. So we used agents that had become clinically available for rheumatoid arthritis to see if we could in any way impact favorably patients with this syndrome. And we found in both instances, both with etanercept and infliximab, that this syndrome was not impacted upon favorably. We also were aware of something along the lines of 10 years of data that suggested PARP inhibitors have some favorable effects on mitochondria within muscle. Preclinical data that showed fairly consistently that those animals became much more robust, gained weight, showed favorable effects, salutary effects on muscle with PARP inhibitors. But we looked at this in people, in patients with cancer, and we found PARP inhibition really had no effect also. We also looked at creatine. And the reason we looked at this is because there have been many studies in other settings, muscular dystrophy, where it was demonstrated that individuals got stronger, that they showed changes in body composition which were favorable in favor of muscle. And we thought this is a good opportunity to maybe help patients with creatine supplementation. This was a double-blinded, placebo-controlled trial run within the Alliance, and what we found was no effect. We looked at weight, we looked at appetite stimulation, we even did body composition assessment with bioelectrical impedance, and again, it was a flatly negative trial. And we also looked at bortezomib. There were some studies back in the early 90s, preclinical studies in animal models, which suggested that the proteasome was in fact where most of the muscle was wasted, where basically muscle breakdown occurred primarily. So looking at bortezomib in patients with pancreas cancer seemed to be a worthwhile pursuit, but we found no evidence of benefit with the use of this agent. So what does work? Well, consistently, the interventions that seem to help, and albeit they help modestly, are hormonal therapies. Megestrol acetate, corticosteroids, and then more recently there are some data to suggest that anamorilin, which I'll talk about in just a few minutes here, might also be effective. These are data from several years ago, which I think are highly impactful, a study by Charles Laprinzi and others, which used a validated questionnaire, which I summarize here, How's Your Appetite? 133 patients, none of whom had hormone-sensitive tumors, and all of whom had metastatic cancer, and all of whom had incurable disease. Patients were randomly assigned to receive either megestrol acetate or placebo, and as you can see here with that very bottom line, yes, 70% of patients who received the megestrol acetate described an improvement in appetite. 44% of patients who received placebo described the same. Overall, 20 to 30% of patients described that they felt somewhat better from an appetite standpoint with the use of megestrol acetate. And there's a little footnote down there to say that a placebo-controlled trial with the use of corticosteroids also produced similar sorts of findings. And megestrol acetate, with repeated assessment against other sorts of interventions that seemed highly promising, has held true as being the most important drug. This is a study that looked at dronabinol, or basically a marijuana derivative, and tested in 400 patients dronabinol versus megestrol acetate. In this study, again an Alliance trial, we found that it is in fact the megestrol acetate that was more effective as an appetite stimulant, and really with respect to every other type of endpoint that we looked at. Similar findings with eicosapentaenoic acid. Eicosapentaenoic acid is thought to be a suppressor of inflammation. There have been several clinical trials, mostly in patients with pancreas cancer, that seem to suggest phase 2 studies, other sorts of studies, that eicosapentaenoic acid can make a major difference, even generate a survival advantage in patients who received it. But we compared it to megestrol acetate. We saw no improvement in appetite, no improvement in weight, no improvement in survival. It was basically a negative outcome with respect to that agent and a positive outcome with respect to megestrol acetate. Just to talk a little bit further about progestational agents, limited benefit. They stimulate appetite, but modestly and only in a few patients. They have never demonstrated a survival advantage in this setting. Yes, maybe in breast cancer patients who were using their drug to get their breast cancer treated, but not in the setting of anorexia or cancer-associated weight loss. There's been no improvement in global quality of life. We studied this as well, and what we found is that megestrol acetate and these other agents improve appetite, but they don't have this widespread improvement in global quality of life that we see with other sorts of interventions in other settings. And progesterones, as people here know, can be thrombogenic and sometimes generate other adverse events, although keep in mind that the rate of that is relatively low, well below 10%. I mentioned anamorelin, which is a oral ghrelin mimetic, another hormonal agent. This was a registration trial that was conducted and just published in the last few years. These investigators demonstrated that there was some increase in muscle mass as a result of ghrelin or anamorelin. More saliently, they also noted some improvement in appetite, but this was not FDA approved as a result of this trial because the primary endpoint of muscle functionality was not met. The agent currently remains unavailable, and one might question, is it going to be that much better than megestrol acetate, especially if it's such an expensive drug, if it ever does get approved? So just to summarize, we have the patient who is symptomatic, who has an incurable refractory malignancy. As Thor Halfdanderson and others have shown, dietary counseling, talking with the patient, acknowledging that they're struggling with this is of huge help. For the few patients who do want some sort of intervention, if life expectancy is viewed in terms of months, megestrol acetate is thought to be a reasonable choice, except in the situation where a patient has had a deep vein thrombosis. Life expectancy shorter, given the side effect profile of dexamethasone, basically weeks would be more appropriate. If the life expectancy is weeks, it's more appropriate to use dexamethasone. So can we launch new paradigms for clinical investigation in this setting? And I would submit to you that the answer is yes. And perhaps with all the successes that we're starting to see in trials with anti-neoplastic agents, maybe we can use some of these same approaches to help patients with this syndrome. And I'm going to give you a few examples over the next few slides. For example, exploiting known pathways of muscle wasting in the setting of cancer. We know multiple different targets are at work when patients manifest with weight loss in the setting of cancer. We also know, as I mentioned to you, that the proteasome pathway is revved up, and there are also data to show that autophagy is revved up, and I show you that arrow that shows where those two pathways converge and result in muscle wasting. We are aware of the above, and we have a pilot study going on right now looking at disulfiram or antabuse. The reason we picked this agent to study is in part based on some data, some very preclinical data that showed suggested efficacy, but also from a mechanistic standpoint is that antabuse inhibits both the proteasome and it also inhibits autophagy. So we're working on it. We'll see what happens. We've also tried to explore novel circulating targets, and this was a study that we published a few years ago. It was funded by industry, but it was in fact a partnership with industry where we worked together to try to identify, again, targets that were circulating in patients with lung cancer, some of whom were losing weight and some who were not. It was basically a case-control type study design. We identified GDF15 as a potential target. It sort of rose to the top of the list because it seemed to have the most pronounced difference in circulating levels based on degree of weight loss. We even took it further and looked to see whether it had any type of a prognostic association, and it did seem as if it was a very strong prognostic indicator as well. But we cooled our heels a bit because this agent, which is involved with tissue regeneration, there were some studies that came forward that seemed to suggest that it made the tumor worse, so for that reason we somewhat abandoned it. But what we did do was we decided to try to push a little bit further with this whole issue of immune monitoring. We put forward a proposal relatively recently that looked at CyTOF in conjunction with exercise with the long-term goal of identifying groups of patients who might be able to benefit from immune profiles. And we recently learned just in the last couple of days, actually on Monday, that our proposal was funded. So we'll be moving forward with this in the hope of perhaps coming to the Alliance in the future with some preliminary data that might justify a larger trial. I think it's also important, as a third example, to look at animal models and to identify muscle targets in this respect as well. And I feel very fortunate to have been able to collaborate with many really outstanding basic scientists, including Dr. Min Lee at the University of Oklahoma. Min Lee showed not too long ago that this whole issue of, in pancreas cancer patients, this whole issue of ZIP4 seems to make cancer worse and is a very notable potential target for the treatment of pancreas cancer. But together we also generated some data to indicate exactly how ZIP4 might be implicated in muscle wasting. So as a result of ZIP4 being a zinc transporter, and as a result of the fact that there are these extracellular vesicles that ZIP4 allows, basically enhances the extracellular vesicles to leave the cell, with also in conjunction with heat shock proteins, eventually these vesicles lead to attack normal muscle and lead to muscle wasting, as you can see in this slide. I think this is important for several reasons. One is ZIP4 might be a potential therapeutic target, not just for cancer treatment, but perhaps also for wasting. But also, and I think very importantly here, what I think this slide shows that hasn't been shown all that well in the past is that there is a very direct link between the cancer and the muscle and the wasting. And so this slide, in effect, tells us that perhaps there's more going on here than this wasting syndrome being an epiphenomenon. This is a direct effect of the cancer, and what is important here is that perhaps we can intervene independently of what happens in the cancer. Perhaps we can intervene in muscle and allow patients to at least achieve better quality of life as a result of that sort of an intervention. Another example, working with cancer patients to explore muscle targets. This is a nascent effort at our institution at Mayo, but we've started harvesting muscle in many patients, and we've started trying to analyze what's going on in that muscle in the setting of wasting. And what we've started to do is identify potential targets with the goal down the road that we could come back to the Alliance at some point with a trial that is very mechanism-based and that could potentially translate into benefits for the patients whom we see. So is cancer a worthy target, or is it just an epiphenomenon? Well, obviously, I think it's not an epiphenomenon. Epiphenomenon is defined here by a marker of outcome, but not a direct component within the causal chain. Again, I don't think this is an epiphenomenon, and I say that based on the fact that the clinical characteristics of muscle wasting, the mechanisms that lead to it, and the outcomes that are tightly and consistently linked with it are such that it just doesn't make sense, in my opinion, that this is an epiphenomenon. Cancer cachexia is directly causing some of what our patients are dealing with, and it behooves us to try to intervene to reduce some of the outcomes associated with this syndrome, intervene in the setting of cancer cachexia trials. And finally, I think this is probably not an epiphenomenon because we've already demonstrated that, at least with the modest types of interventions that we have, we can intervene and make outcomes a bit better, as seen in the randomized trials that I've shown you with the hormonal agents that I had shown you, megestrol-acetate, corticosteroids, and even anamorelin. And I'd like to end here on a note of hope. There is this issue of plasticity. There's a thinking sometimes, well, if a patient is losing weight, is losing muscle, all is lost. They'll never get it back. But we've seen time and time again in the clinic, sometimes as a result of effective anti-neoplastic therapy, the patients can get better. They can become functional. And we've also seen it with athletes who sometimes do some amazing feats after having been diagnosed with cancer and after having been successfully treated for their cancer, which raises the question, if we could intervene on the muscle level specifically, perhaps we could make patients get better in parallel with cancer therapy. So in conclusion, cancer cachexia is a multidimensional syndrome characterized by poor appetite, weight loss, loss of muscle, decline of functionality, poor quality of life, and diminished survival. Appetite stimulation with hormonal therapy provides palliation, and dietary counseling might benefit too. Successful approaches used in the development of anti-neoplastic agents should be used here too, and at least I believe that cancer cachexia is a worthy therapeutic target and one that deserves ongoing study within the Alliance and hopefully also within the Cancer and Older Adult Committee. I'd like to just end by acknowledging some people whom I think are very important. Some of them have already been mentioned in the talk, and I certainly can't go through the whole list, but very early in my career, when I was in training, I received a tremendous amount of insight from B.J. Kennedy, under whom I trained. Other people who, very early in my career, when I was in training, influenced the way I think about things, Irv Rosenberg, Joel Mason, Ronen Rubinoff. I'd also like to just recognize Jan Buckner for all of his compassionate mentoring that he gives to so many of us. I'd also like to point out some of the really important key translational investigators I've really had the privilege to work with. Martin Fernandez-Zapico at Mayo was one, Rajiv Kumar is another, and Ken Kaufman, who actually does work in injured veterans, is another person with whom I've collaborated and is starting to get more interested in cancer. And I'd also like to acknowledge the funding that I've been able to acquire through the years. And more specifically, I'd like to acknowledge the Alliance for Clinical Trials. The infrastructure here that allows us to do such important research is so invaluable and so meaningful, I think, to all of us. Thank you very much.
Well, thank you, Amina, for bringing knowledge and insights to, I think, what has been for all of us a really confusing and difficult area of oncology. That was really, really wonderful. Okay, now I would like to invite up, we're going to have discussions from two of the co-chairs of the Immuno-Oncology Committee. First, Beth Mittendorf, who is going to talk about current status of immunotherapy in the NCTN. And then I will let you go ahead and introduce your partner when you're finished with your part. Thanks.
Super. All right, well, thanks, Monica. If you could put up my slides, please. So I actually want to thank Monica and the Alliance Executive Committee for recognizing the importance of immuno-oncology and elevating us from a working group to a committee. This occurred last fall. Right now, after seeking input from existing committee chairs, we have 43 members, but we, of course, are open and inviting of others. So I would highlight that we do have a meeting this afternoon from 4:30 to 5:30 with the agenda here, and I'll be touching on two of these agenda items with some of my last few slides. A few disclosures, and then immunotherapy. So obviously immunotherapy is a very hot area. In 2013, it was named Science Magazine's Breakthrough of the Year. And what we're seeing on the cover depicted here is the anti-CTLA-4 molecule shown in a salmon color, seeming to be honing in on CTLA-4, shown in blue, expressed on a T cell. Immunotherapy has also been recognized by ASCO as the clinical cancer advance of the year, both in 2016 and 17 for the success of checkpoint blockade, and more recently in 2018 for the success of CAR T cells that are targeting CD19. So, of course, we know now that there's a tremendous interest in immunotherapy, and most of our scientific journals have sections or dedicated focus on tumor immunology, immunobiology, immunotherapy, and of course, it's penetrated the lay press as well. So the first success in immunotherapy was ipilimumab, which is the molecule that targets the CTLA-4 molecule on the T cells. This was FDA approved in March of 2011, and the approval came on the heels of this clinical trial that enrolled patients with unresectable stage 3 or 4 melanoma. And the trial demonstrated an improvement in overall survival with ipilimumab when compared to giving another therapeutic, investigational therapeutic, which was actually a vaccine. And so not only did this trial lead to approval of the agent for our metastatic melanoma patients, but it also led to the awarding of the Nobel Prize to Jim Allison just this past fall. And I would note that Jim was awarded this in collaboration with Tasuku Hanju, who's a very talented immunologist who, while Jim was working on CTLA-4, Tasaku was working on PD-1 and the PD-1-PD-L1 axis, which we've all become quite familiar with. And in fact, it was an agent that's targeting the PD-1 axis that was the next to receive FDA approval. And it actually took about 3.5 years after IPI was approved for nivolumab to be approved. It was approved in patients with metastatic melanoma who had progressed on ipilimumab, or if they had an appropriate mutation, progressed on a BRAF inhibitor. And it was approved based on the findings of an objective response rate of 32% in patients who received nivo compared to 11% for those who received the investigator's choice chemotherapy. So it took 3.5 years, but we had another FDA approval in December of 2014. And since then, there's been really an explosion. So this is from the AACR Cancer Progress Report in 2017, where it was noted that in August of 16, we had 4 approved agents in 5 tumor types, but by the middle of the summer of 2017, there were 6 approved agents, 7 tumor types, as well as an indication that was histology agnostic for MSI-high tumors. And then in the most recent report from the AACR, this is as of July 2018, 1 or more checkpoint blockade agents are approved for treating 19 different types of cancer, and still with the MSI-high indication. And I would note that there are other approved immunotherapeutic agents as well. There are 7 vaccines approved, 2 forms of cellular therapy, those are the CAR T cells, oncolytic viruses, other immunomodulatory agents to include TLR agonists, and a CD3 targeted bispecific. Now, there's obviously tremendous interest in developing immunotherapy, and I'm going to just give some data about what's going on in the field, focusing on PD-1, PD-L1, because that's the target that is under most investigation right now. And the next few slides have some data that were put together by the Cancer Research Institute and published in the Annals of Oncology in January of 2018. So I would suggest that you can take the numbers that I'm going to show you and inflate them probably about 5%. But in January of 2018, there were 164 agents targeting the PD-1, PD-L1 axis that were in development, including 50 that were already in clinical trials. You can see here this included monoclonal antibodies, bispecific, small molecules, and other biologics. In addition to looking at these as monotherapy, there's tremendous interest in looking at these as combination strategies. And what's shown here on the equivalent of the x-axis are the different approved PD-1, PD-L1 agents. And then what you can see here is the number of different combinations they're being investigated with the most common partners being other immunotherapeutic agents, targeted therapies, and chemotherapy. And we can look at this a little bit differently. In this figure, what you're seeing, again, is combination strategies, but here the size of the bubble correlates to the number of trials. So you can see that there's 251 trials in January of 2018 that were looking at an anti-PD-1 or PD-L1 agent in combination with anti-CTLA-4. And then looked at yet another way, this is the increase in the number of combination strategy trials over time. And so you can see in 2017, obviously a larger number of trials. And in this graph, the size of the bubble correlates to target enrollment. And so what I'd highlight is that in 2017, the planned new enrollment was over 52,000 patients. And this is just for the PD-1, PD-L1 combinations, not for the many other immunotherapeutic strategies that are of great interest. And I highlight all of this because I think it's critical that we recognize that a lot of this is going to be driven by our pharma partners, but there's a really important opportunity for the NCTN to think about what are the trials that we are best positioned to initiate and complete. And so with respect to the NCTN portfolio, as of May 7th, there were 34 trials, and I would note that on May 8th, I got an email suggesting that my slide was out of date. There's actually 2 more, so 36 trials, 5 from the Alliance. You can see the distribution here among the other groups. With respect to the Alliance trials, these are the 5 trials. You can see we have studies in colorectal cancer, urothelial, muscle-invasive cancer, rare GU tumors, sarcoma, and Merkel cell carcinoma. In addition, we have a number of trials that are being conducted through the Alliance Foundation. There is one that's actually closed that looked at pembrolizumab in non-small cell lung cancer. There's 2 actively accruing investigating atezolizumab, one in lung cancer, another in breast, and then 2 that are pending activation looking at nivolumab and durvalumab, both in lung cancer. So I wanted to make a few comments before turning the podium over to David to let this larger group know what the goals of this newly established Immuno-Oncology Committee are. Specifically, our goal is to ensure that the Alliance and the Alliance Foundation perform cutting-edge immunotherapy trials that will advance the field for the benefit of our patients. Our purpose is to provide immuno-oncology expertise to the Alliance. We intend to do this by leveraging the existing strengths within disease groups and other committees to create a multidisciplinary committee of clinicians and researchers who have an expressed interest as well as experience with immuno-oncology to harmonize IO trials and biomarkers within the Alliance. We seek to serve in an advisory role to disease committees for the development of trials and correlates. And in this sense, we anticipate being highly collaborative with the different disease site committees as well as with the translational research program led by Fraser Simmons. And finally, we are positioned to develop trial concepts that don't otherwise have a home in one disease site committee. So this could be trials that would cross diseases or address orphan indications. And here we'll have a real opportunity to collaborate with the Experimental Therapeutics and Rare Tumors Group. Our objectives then are to review the IO trial concepts, to integrate with translational research program, again, Fraser's group, to optimize SOPs for biospecimen collection, processing, and storage. This work is already well on its way, being led by Andy Nixon, one of my co-chairs. We intend to provide input regarding correlative studies, and in this capacity, we will be interacting with the Cancer Immune Monitoring and Analysis Centers, and I have a slide on this next. And then, of course, we want to serve as a central resource within the Alliance for IO-related information. So with respect to the CIMACs, so for those of you who are not familiar with this, the CIMACs were awarded in the fall of 2017. The purpose is to serve as the infrastructure for correlative studies in NCI-sponsored clinical trials involving cancer immunotherapy. So if you're doing a IO trial that's early stage, you can apply to have the correlatives be done through the CIMAC. So the CIMAC labs will actually do the assays for these early phase studies, as well as provide the computational statistical support. There were 4 sites that were awarded CIMAC grants: Dana-Farber, the Icahn School of Medicine at Mount Sinai, which is the Alliance's primary CIMAC, although we could utilize any CIMAC depending on the needs of the specific study, MD Anderson and Stanford University. And then I have 2 final slides to just briefly introduce the concept of the iMatch. And I'm going to highlight that at this afternoon's open meeting, Andy will be giving us about a 20-minute talk about the CIMACs, and then Matt Galsky is going to be giving us about a 20-minute update on iMatch. So iMatch is in the spirit of match or combo match, which most of you are familiar with. The NCI intends to have an iMatch trial, and we had the opportunity in early April to send a group of Alliance investigators to a planning meeting, which I thought was really critical because it allowed us to have input kind of at the beginning as this whole effort begins to roll out. It is very early still, but what the thought is that there will be a number of assays that are going to be CLIA certified that can be performed that might inform the immune status of a patient's tumor. In addition, other markers that may not be CLIA certified but still identified as markers of response to immunotherapy. And then based on the immune profile of the tumor would indicate which trial that a patient may go on. And this is a potential design starting with patients who are checkpoint inhibitor naive, receive anti-PD-1, and then depending on response, go on to another study. So again, very early, and I'm appreciative of my colleagues who were able to attend the meeting in April, to include Matt, who will update us a little bit more about iMatch this afternoon. And so with that, again, I would just like to welcome and invite everybody who's interested to attend our meeting from 4:30 to 5:30. In addition to Matt updating on the iMatch and Andy updating on the CIMAC effort, Heather MacArthur has agreed to give an update on immunotherapy in breast cancer, which is the disease site that's had the most recent FDA approval for an IO agent. And with that, I'll end my comments and ask my colleague, Dr. David Kazona, to come speak. So I feel very fortunate that David has agreed to co-chair this committee with me, given his extensive experience with respect to IO-related toxicity and adverse events, and in his role as the PI on a large biospecimen collection protocol for patients who are experiencing these toxicities. David?
Well, thank you so very much, Beth, for the kind words. Last month, I was at fantastic back-to-back conferences, one organized by the AACR and NCI, and the second by the FDA and Project DataSphere, on this very topic of IRAEs that you see with checkpoint inhibitors. And that lasted 3 days, so I'll try to scratch the surface in the next 20 minutes. No disclosures. And we'll talk a little bit about the background and pathophysiology of these toxicities, the assessment and management of these, and then finally a bit on future directions and ongoing research, including the biorepository. And so what are immune checkpoint inhibitors? I think most of you know, but just to go very briefly over this, the immune system is extremely elegantly managed, and when this goes wrong, we see this in the form of autoimmune disease. Early on, T cells must engage with antigen-presenting cells, here in the case of a dendritic cell, by interaction between its T cell receptor and the antigen presented by MHC molecule. And there must also be co-stimulatory engagement as well. But as you have this happen, CTLA-4 becomes translocated to the membrane and dampens the signal so that you maintain immune homeostasis. Mice, for example, that are engineered to lack CTLA-4 die of severe lymphoproliferative disorder, showing what happens in the loss of CTLA-4 from the entire organism. These T cells then find their way into the tumor microenvironment where they encounter tumor cells that express the antigen that they recognize. But then again, there is another instance where a brake can be applied to this interaction where the tumor cell can express PD-L1, which again puts the brake on activation of the T cell. And it's within these two steps of putting brakes on the immune system that we have developed this plethora of agents. It's been an absolute landslide since the first approval of ipilimumab in 2011 for the indication of melanoma. And since then, over the subsequent 8 years, we've had this accelerating number of approvals, including 5 from just this first half of the year alone in both pembrolizumab and atezolizumab. And so with this, we are going to increasingly encounter these toxicities in practice. And these ICIs can result in inflammation of, well, literally any organ. The most common that we see would be those that target the GI tract, the form of colitis, endocrine, such as hypophysitis and autoimmune diabetes, skin in the form of rashes, and liver as hepatitis. And what I've come to recognize is that multidisciplinary collaborative management of these toxicities, both on trial and as standard of care, is absolutely key. For every one of these itises, there is an ologist that can help, a rheumatologist, a dermatologist, a gastroenterologist, you name it. And it's really that collaboration between all of these branches of medicine that made our workshops on IRAs as successful as they've been. And what's the incidence of these? So they're more common than I initially really thought. The lower grade toxicities in the grade 1 to 2 range appear quite commonly, and in fact, one could see that maybe a majority of patients will express these lower grade toxicities. They're a bit more common with CTLA-4 agents compared to PD-1 and PD-L1 antibodies, but nonetheless, they are quite prevalent, and even to the extent that they become quite severe. On the right, you see the distribution of toxicities in the grade 3 to 5 range. And so there are numerous ideas about the mechanisms for these immune-related toxicities. We don't have the full answer, but a few examples that are shown in this wonderful New England Journal review suggest that it could be increasing T cell activity against antigens that are present in the tumors, but also in the healthy tissue. It could be due to increasing the levels of pre-existing autoantibodies, such as these antithyroid antibodies. It could be increasing the level of inflammatory cytokines, and it could be enhancing complement-mediated inflammation due to direct binding of an anti-CTLA-4 antibody with CTLA-4 expressed in normal tissue. Or there's another example where the heart expresses PD-L1, and that this could be targeted by our PD-L1 antibodies. So just to provide a couple examples, I have three here highlighted just as examples. Colitis presents itself as watery diarrhea, cramping, urgency, and abdominal pain. And the grading is based on diarrhea and the number of bowel movements above baseline per day. It's maybe not the absolute best measure, but it's what we have from the CTCAE. And we're looking at grade 1 being less than 4 of these, grade 2, 4 to 6, and grade 3, more than 6 bowel movements above baseline. But there's a wide differential for diarrhea. It could be infection, such as with C. difficile or other pathogens. And if there's blood in the stool, my GI colleagues tell me you should start thinking elsewhere, for example, peptic ulcer disease or malignant bleeding. Evaluation to confirm this, fortunately the GI tract is accessible to endoscopy and colonoscopy, and so biopsy can be very informative here. And here's a picture from a colonoscopy performed 4 weeks after initiation of ipilimumab for confirmation of colitis. Dermatitis is extremely common, and the most common manifestation is as sort of a generic maculopapular rash. But there are more severe forms such as bullous disease, Stevens-Johnson syndrome, and TEN. Grading is really based on what percentage body surface is affected by the rash. But again, this is a toxicity with a wide differential, including infections, allergies of other types. But again, here is to highlight the fact that obtaining a tissue sample, which is also fairly straightforward to do here via skin biopsy, can be highly informative. Here you can see T cells and eosinophils in this H&E section here on the right, illustrating this form of presentation. And then pneumonitis, again, can become vague symptoms. Dyspnea, cough, chest pain, fever, hypoxia, states that you might see in a lung cancer population pretty commonly. But that said, one after considering differentials, including infections such as bacterial pneumonia and, say, radiation exposure for radiation pneumonitis, one can obtain chest CT with contrast and see, for example, in this example, a patient who received nivolumab for metastatic lung cancer had a very nice response in the disappearance of the pulmonary nodule seen bilaterally, but some months later developed this inflammatory infiltrate that responded quite quickly to corticosteroids. Hyperprogression is an increasingly recognized devastating potential outcome of initiation of ICI therapy, where here you have an example on the far left of a patient with a relatively modest sized nodule in the lung that grew relatively slowly over a period of a few weeks prior to initiating an ICI, and just a handful of weeks later, the rate of growth of this lesion increased dramatically. And so there is the potential, again, of a different kind of harm that one could elicit by initiating one of these agents. This is not just a lack of response, this is an acceleration of their disease and something that we should certainly try to understand better. So there are more toxicities at play than just the traditional ones of like symptoms and side effects. And the timing of these IRAEs, most commonly they occur within the first few weeks to months after treatment initiation, but they can sometimes show up surprisingly early, and they can also appear after discontinuation of the therapy, so don't stop thinking about these just because you stop the ICI. Prolonged treatment, though, it doesn't actually seem to result in increased cumulative incidence, so there's at least that. And this figure on the right shows a sense of some of the kinetics of these different toxicities after starting ipilimumab, with rash being a relatively early presentation. Interestingly, there does appear to be an association between the development of these toxicities and anti-tumor efficacy. So maybe it kind of makes sense, but people have seen early on with immunotherapies, even predating ipilimumab, but that you can see vitiligo in the setting of treatment for melanoma. And here, there is a substantial survival improvement upon those patients. There were about 3.5% in this study who experienced vitiligo, compared to those who did not in stage 3 to 4 melanoma, here treated with ICIs. And on the bottom here, you see that IRAEs in general have been associated with overall survival in non-small cell lung cancer treated with nivolumab. So how do you come to recognize these? So in general, at baseline, one would take a careful clinical history, definitely focused on the existence of any prior autoimmune disease, because it's unclear as of yet how much this increases the risk with these drugs. Look for endocrinopathy or infectious disease, bowel habits, and do a good physical exam, including a neuro. Obtain pretty standard labs, but consider getting TSH because of the the often presentation of hypothyroidism, pulmonary, just O2 sat, PFTs for high-risk patients, and imaging as indicated. And then monitoring can include standard CBC and comprehensive metabolic panel, TSH, and then other labs here as you suspect individual toxicities. So the general approach when you do encounter these, this is just sort of a general rule. There are good guidelines I'm going to show for individual toxicities, but for grade 1 disease, continue the ICI with close monitoring. For grade 2, hold the ICI and do not resume it until the toxicity is resolved to at least grade 1 or lower. And if symptoms persist for greater than a week, consider starting corticosteroids. If you get to grade 3, discontinue the ICI, start prednisone at higher dose, and then taper slowly. And then with grade 4 in generally, you'll permanently discontinue the drug. Fortunately, since that's really just sort of a rough overview of what you do, there are excellent guidelines that have appeared over the past year on how to manage these toxicities, including an NCCN guideline and this fantastic JCO review. And they present charts like these. For the sake of time, I won't belabor them, but they, in general, will help guide you toward recognizing the differential diagnosis for these toxicities and management. And it's not indeed a one-size-fits-all approach. For example, with the dermatologic toxicities, one can consider topical agents and try to prevent the use of systemic corticosteroids, because the jury remains out about whether initiation of corticosteroids can blunt responses to ICIs. The study data so far is quite mixed, with some suggesting that having them on board at the start of an ICI could be deleterious to outcomes. Other studies showing it may not matter, but then you have a mixed picture given that you might have, on one hand, a better response to anti-tumor efficacy if you develop one of these toxicities, and then you just cancel out that benefit if you then start corticosteroids to treat the toxicity. It's hard to know, and that's part of what we hope to understand better. But these ICI agents, the anti-CTLA-4, PD-1, and PD-L1 drugs that we've become familiar with are really only the beginning. I tried to show a simpler cartoon earlier on in the talk, but this is an example of something that more closely approximates a real picture, where there are numerous positive and negative regulatory signals that occur among each of the different constituents of the immune system. And there's the notion that multiple immune cells, for example, the Th1 cells, TILs, and macrophages, come together in promoting anti-tumor inflammation. And so an increasing approach is to consider not just cutting the brakes, but also stepping on the gas. But as you can imagine, when you do this, you would expect to see increased toxicities. And so we'll have to keep a close eye on this. And as Beth showed, there are numerous trials ongoing right now in the IO space. In fact, there are over 2,000. And interestingly, the majority of these now are looking at combination therapy approaches. Certainly the dual checkpoint blockade between CTLA-4 and PD-1, PD-L1, but also more standard agents including chemotherapy and radiation, but quite a host of additional more novel immune oncology agents. And so why do we want to study these systematically? Throughout all of medicine, the overall benefit of any therapy is determined by the benefit-risk ratio. Who are you standing to help? Who are you standing to harm? And if you can better understand who's on each side of this fence, then the right therapy can be chosen for each patient. However, the risk of these toxicities like tumor responses vary quite a bit among individuals, and we're only really just starting to understand why. AFT42, just to plug this, is just getting activated now, and it's looking at the question of could these therapies be safe in the setting of pre-existing autoimmune disease. For the most part, our protocols to date have had existing autoimmune disease as an exclusion criterion. Here, it's the inclusion criterion for the study of these 72 patients to see whether using nivolumab may be safe in the setting of advanced non-small cell lung cancer. And then the biorepository. So it's our goal to look at patients enrolled on the NCI-IO trials who develop the more severe toxicities, the ones of great consequence, grade 3 or higher, and collect biospecimens and data at multiple time points right at the presentation of their grade 3 or higher toxicity, 1 month later to take a look at resolution or lack thereof, and to continue to collect data from these patients. And why do we want to do this within the NCTN? We actually do treat a number of patients with these agents. So as of earlier this week, I counted up that over 7,000 patients have been accrued to date on adult US NCTN studies of these 3 types of ICIs, and that we stand to accrue over 6,000 additional patients just to those studies that are currently active, and there's a whole slew of studies that are pending activation at this point. And why we need to collect these sort of specimens prospectively is that the biospecimens that are collected on therapeutic trials, and I'm delighted to say that they most always are being collected on these trials, but those biospecimens are really timed with respect to the treatment and assessment of tumor responses, and not necessarily timed with the toxicities, when the IREs actually appear. And so here we have the opportunity to look more closely at the toxicity and biomarkers of their development. And then we have an opportunity here to standardize the samples that are collected across all of these trials, because each of the trials right now, for many good reasons, have highly trial-specific collection of samples. And so this just gives an illustration of the kinds of samples that are collected on alliance studies, but you can see that there is a robust collection built into each of these protocols. And here for our biorepository, the eligibility is pretty straightforward. One is to have received 1 or more IO therapeutics of interest and experienced 1 or more serious IRAEs. So this would be grade 3 or higher toxicities based on CTCAE. Rare infections will also be of interest, as well as the phenomena of hyperprogression. We're starting out with the tried and true ICIs, the approved and well-characterized CTLA-4, PD-1, and PD-L1 inhibitors, but we hope to expand from this. And then we've developed basically this index of the IRAEs as they would be identified by investigators, and tried our best to correlate this with CTCAE terms. But in doing this, we all recognized that this is not easy. I mean, myocarditis, for example, could manifest as this entire slew of different potential toxicities coded by the CTCAE. So we hope along the way to understand which of these actually correlate with myocarditis that can be confirmed in the samples, and likewise for these other toxicities as well. Hyperprogression has no universally agreed upon definition. Each of the current publications use a little different one, but here for this study we're going to look at time to treatment failure of less than 2 months and a greater than 2-fold increase in tumor growth rate compared to pre-IO therapy, because we very much want to really understand where these therapies are truly causing a rapid problem for patients. The key clinical data collection, for the sake of time, I won't go through, but generally tied to understand the IRE better, and biospecimens that were collected include those upon IRE identification and 1 month later, done in the form of color-coded kits, where we're going to be looking for both the primary tumor, but a robust set of peripheral blood samples so that we can look at circulating biomarkers and PBMCs to better characterize the toxicities. And from those patients, especially those with colitis, looking at stool samples, given that the microbiome so far has been one of the places we've identified apparent differential risk to IRAEs. And then this illustrates the specimen collection and submission. So current status and next steps, we are going to be opening this this summer across the 4 adult cooperative groups. We have study champions identified at each who are excited about the study, which I'm very gratified by. And we don't have any pre-identified analyses right now for these samples. The idea is to, once we have them available, really look for the best science that can be done with them. And so these are acknowledgements. Thank you so much.
All right, well, thank you, and really thank you all for attending the plenary and the meeting. Enjoy the rest of the meeting, and see you tonight at the dinner.